first to sixth cranial nerves, already we have discussed the second cranial nerve in the last two classes, the color vision, visual acuity, and we have discussed the field of vision also. Today we are going to discuss the remaining cranial nerves. The learning objectives for today's session is you must know the what are the different cranial nerves, how you will test these cranial nerves. The first and foremost is the olfactory, and we will check the oculomotor, the opticians and the trochlea together because they supply the extraocular muscles. That is the thing. Other one is the trigeminal nerve. We are going to how we will test. We know in the next few slides. The first and foremost is the olfactory. It is the sense, the smell. For this you require the small bottles containing the different essence, like the commonly the asafoetida, the ingua, the coffee or the clove oil, even the peppermint, even you can use the camphor and the lemon chocolate. Here you use the lemon. Before first you require these things before you test the individual. First you have to check whether the patient is having the clear airway. Each nostril you have to check whether he is having the clear airway in each nostril. Then you have to ask the subject to occlude the one nostril, and you have to sniff through the other nostril, and you must be able to, the subject must be able to identify the these things. But here the patient is seeing but actually some of the tests we ask the subject to close the eyes, otherwise with the open eyes he can check. But here they are using it the tissue bottle. Suppose if you are using the bottles containing essence, you must label those bottles. You should not label with their generic name, but you have to label with the numbering 1, 2, 3, 4. You have to label the bottle numbering, but you should not mention the name of the content on the bottle. Otherwise, they can direct. Otherwise, suppose if you label with the numbering, even sometimes suppose we are using the camphor, these things, suppose if you're able to see, we can directly identify the substance without smelling that is why ask the subject to close the eyes. For coffee, even cinnamon, chocolates, every day these are the things that can be used to test the sense of smell. Ask the subject to close the eyes, occlude one is nostril. Before that, you have to test whether the nostrils are patent or not. Then you have to ask him to smell and distinguish the odors of each testing substance, each nostril separately. Then again, you have to repeat the same thing. You ask the subject to occlude the other one and smell if you're using the clove oil or the camphor, you can. And then immediately after this, you ask the subject to try the distinguish between the adapted or different the alcohol also you can use this. Then what are the different abnormalities? Anosmia refers to the complete absence of the smell. The parosmia refers to the alteration in the smell sense. Hyposmia means the decreased sense of smell. Increased sense of smell you see in the adrenal insufficiency. The anosmia, the commonest cause is the cold. Nowadays, everybody is worried about the COVID. COVID is also can cause the anosmia, and agusia it can cause the anosmia. Okay. What are the different causes of the anosmia? The most common cause is the common cold and any closed head injuries, subfrontal meningiomas, previous bacterial meningitis or sinusitis, or any local lesions like any polyps which are responsible for that. Even Parkinson's disease also can cause the anosmia. Then we'll discuss regarding how we'll examine the third, fourth, and sixth. Why you are examining all these together? We all supply the extraocular muscles. That is why you are discussing the three cranial nerves in it together. The third and fourth usually considered together because the function as a physiological unit in control of the eye movements. LR6 and SO4 the most common mnemonic is given by the Chaurasia. The left lateral rectus is supplied by the sixth cranial obstruence nerve, and the superior oblique is supplied by the trochlea. The sixth cranial nerve supplies the lateral rectus, and the fourth cranial nerve supplies the superior. Remaining all the extraocular muscles, the superior rectus, medial rectus, inferior oblique, all these are supplied by the third cranial nerve. Even the third cranial nerve even supplies the levator palpebrae superior. That is the muscle responsible for the elevation of the upper eyelid. Levator palpebrae superior. Suppose you have any defect of this levator palpebrae superior is produce the ptosis. It is a drooping of the eyelid and causes the decrease in the palpebral fissure. Through the ciliary ganglia, it supplies the even sympathetic to sphincter pupillae. It is responsible for the constriction of the pupillae, and it also plays an important role. Already when we discussed in the light reflex and the accommodation reflex, the third cranial nerve plays a very important role in the accommodation reflex and the light reflex. These are the extraocular muscles. This is the elevation, depression, adduction, abduction. These are the all these muscles have the primary function and the secondary function and the tertiary. Suppose if you look at the lateral rectus, it causes the abduction, and the medial rectus adduction. The superior rectus, the primary function is the elevation, the secondary is the intorsion, and the tertiary is the adduction. The inferior rectus, the primary function is the depression, and the secondary is the extorsion and the adduction. And the inferior obliques, the primary function is the extorsion, and the secondary function is the elevation, and the tertiary function is the abduction. The superior oblique intorsion, and it causes the depression, secondary function, and the tertiary function is the abduction. These are the muscles, their function already just now we had discussed. This is the way lateral rectus causes the abduction, this causes the medial rectus the adduction, the superior rectus adduction and the elevation and the intorsion, and the inferior rectus will cause the depression, adduction and the extorsion. Suppose if you see the inferior oblique cause the elevation, abduction and the extortion. The superior oblique will cause the depression, abduction and the intorsion. These are the primary, secondary functions of the obliques and the rectus. And the lateral rectus and the medial rectus will have the only primary function, and the medial rectus, the adduction, lateral rectus is the abduction. What are the conjugate movement? What are the disconjugate movements? The binocular eye movements can be the conjugate or the disconjugate. The conjugate movements are called as the versions. The disconjugate movements are the vergence, either convergence or the divergence. The versions are the movements of the both eyes in the same direction. The right gaze in which the both eyes move to the right side. The dextroversion is the movement of eyes to the right, and the levoversion movement means the movement of the eyes to the left. Dextro means the right side, left. This is the elevation, this is the primary position, and these are the versions. These are the levoversions. These are the dextroversions. These are the levoversions. These are the dextroversions. The elevation, levoversion, intorsion. This is the dextroversion, the divergence, and the convergence. The movements of the disconjugate movements are the convergence. In the versions, they will move in one side direction, at the right or to the left. Here, they will move in a different direction. The convergence, simultaneous movement to the nasal. Divergence means simultaneous movement. This is the convergence. This is the divergence, simultaneous movement to the lateral side. The uniocular movements are called as ductions. The ductions are the monoocular movements of the eyes. The lateral rotations, lateral is called as the abduction, the medial is called as the adduction, upward is the elevation, downward is the depression, another one is the intorsion and the extorsion. the elevation and the depression around a transverse axis. The elevation and the depression occurs around the transverse axis. The abduction and the adduction around a vertical axis. The abduction and the adduction occurs under the intorsion and the extorsion around a anteroposterior. This is the anteroposterior axis where the intorsion or the extorsion occurs. The intorsion or the extorsion occurs the anteroposterior. Adduction and the abduction occurs a vertical axis, and the elevation depression occurs a transverse axis. These are called ductions. Ductions are the monocular movements. Versions are the binocular movements, where you have the conjugate and the disconjugate. The conjugate where you have the versions, disconjugate where you have the divergence and the convergence. Then how will you test the conjugate movements? Normally the movements are simultaneous and symmetric so that the visual axis meet at a point at which the eyes are directed. We will do these movements in a H-shaped pattern. Okay, the head of the patient should be first fixed. You can ask the subject, suppose if he is not cooperating, then you have to fix with the left hand. You ask the to follow the examiner's index finger to the right or to the left. You have to show the finger to the eye, and you ask the subject to, without moving the head, he has to move the eyes following the index finger. And then again you ask the subject to look at the follow finger upwards, downwards in a H-shaped pattern. Okay, ask the subject to follow the finger in a point with either and you have to ask the subject whether he is seeing the single finger or a diplopia. Normally the patients don't have the diplopia. Whenever you have any paralytic paralysis of the particular group of muscles, then only you produce suppose in all gauges you produce the diplopia in the third cranial nerve palsy, and horizontal gaze diplopia is seen in the lateral legs or sixth nerve palsy. And whenever reading the books are coming downstairs, in the down gaze you see in the superior optic or the SO4, the trochlear nerve palsy. Move the object across the plane of and down, and so the shape of the movement should be in the shape of the letter of H. Watch any non-parallelism of the legs. Even watch for the nystagmus. Suppose if the involuntary, suppose if it is moving, the nystagmus is the involuntary movements where you have it has a fast component, the slow component. You have to see, and you can ask the subject again, see whether he has any diplopia, and look for the conjugate gaze. Okay, this is how this is a forward gaze, this is a right gaze, right up, right down. It is a dextroversion, this is a levoversion. This is how you have to examine the all the extraocular muscles. Then what is the diplopia? Diplopia is just seeing an object whenever you have the say one object looks like it. Whenever you have the, suppose already when we discussed these things, suppose if the corresponding retinal points are missing, suppose because of the corresponding of the fusion already when we discussed the field of vision, the binocular vision, when you discuss the central field is that is occupied by the shade by the both the eyes, where you have the fusion. Otherwise you will perceive as the single, the cortex will perceive as a single object. The corresponding points where whenever the same object will perceive as a sun. Suppose if the corresponding points are misaligned because of any paralytic or whenever have diplopia, the eyes are not moving fully seen the peripherally as a diplopia. Whenever the eye which is not moving, the peripheral image as a diplopia. The diplopia gets worse whenever the affected eye moves in the direction of the pull of the affected muscle. Suppose if you have any affected lateral actus palsy, suppose if your eye moves in the direction, the diplopia gets worsened, and the diplopia may be caused by because of the muscle, or it can be caused by the muscle, or it can be caused by the nerve palsy. Suppose if you have any muscular trauma with the intact nerve, also can cause the diplopia, or have the artery fracture where entrapment of these extraocular muscles and can also cause the diplopia of and because of the restriction of the movement. This is how the direction which the the superior rectus and the inferior rectus tested, the lateral rectus to the abduction, the medial rectus adduction, the inferior oblique upward and the superior. This is how the each muscle whenever you are taking the adductions. Test the conjugate movement. Normally the eyes move 50 degrees upward and it moves 50 degrees downwards and 50 degrees inwards, and it moves only 30 degrees upwards. Okay, it moves 50 degrees outwards, 50 degrees down, 50 degrees in only, but only it moves only 33 degrees only in the upwards. The rotation is also tested. Observe any limitation of the direction of the movements you have to test. Then what is the squint? The squints are the heterophoria or heterotropia or the paralytic. It can be a latent squint or the manifest where there is a misalignment of the visual axis, where you see the cover test. We use the layer to diagnose the latent squint. Sometimes the children's normally you don't appreciate the squint whenever they are having because of fever or any health, when they are weak. The squint it looks like a squint. That is most commonly is the heterophoria or the latent squint. Normally you cannot, because of the accommodation other reflexes, and normally you don't appreciate the latent squint. But in heterotropia, the manifest squints, already you can easily appreciate the squint. The paralytic, whenever you have the palsy of the particular group of muscle, extraocular muscle, will produce the squint. And to know whether the subject is having a phoria or not, you can use the cover uncover test to know the squint, whether the presence of squint. The cover uncover test, the test about the presence of the type of the heterophoria. It can be esotropia or isophoria or exotropia or exophoria or hyperphoria or hypophoria. These are the things can be diagnosed by the cover uncover test. To perform this, one eye is covered with an occluder, other eye is made to fix it at an object or a finger. In the presence of the heterophoria, the eye under the cover will be deviated. After a few seconds, the cover is quickly removed. The movement of the eye is, whatever the eye under the cover should be observed. Suppose if the direction of movement eye tells the what is the type of hypophoria. Suppose if eye moves from outwards, from outwards, it is the presence of. Suppose if I will move inwards, it is the presence of exophoria. Suppose if I am moving from the inside, it is a exophoria. From it will move to outward. Suppose if it is moved from the inward, it is a esophoria. The speed of the movement also tells whether the recovery is slow or the rapid. Even hypophoria, suppose if it moving from from to up, or suppose if it is moving from the up to down, will also help you to diagnose the hyper and the hypophoria. Okay, this is the esotropia. Inward deviation is the tropia. It is a outward. Exotropia, hypertropia, moving deviate to the up, and the hypo, it is a deviation to the whenever you cover the eye, it will move from this direction to the outward. That is the esotropia. So suppose if it is moving, it is a exotropia. Suppose if it is coming down, it is a hyperphoria. Suppose if it is moving up, it is a hypophoria. But the tropia is a manifest squint. Phoria is a latent squint. Okay, these are the esotropia, exotropia, hypertropia. This is how the squint looks like. Then what is the paralytic squint? Suppose if the palsy of the third, the sixth, the fourth cranial nerve can produce the paralytic squint. And the third cranial nerve palsy will associate with the ptosis. The ptosis is nothing but the drooping of the eyelid. The eye deviated downwards and out, and it has a large fixed pupil because of the paralysis. The constrictor pupillae, where palsy will lead to the fixed pupil. The fourth palsy, the diplopia, when the affected eye looks down by looking slightly inwards towards the nose. Whenever you are looking at the reading or coming down, you have the double vision in the fourth. The sixth nerve palsy, you cannot abduct. The diplopia when you looking to the side of the lesion. If the patient sees double in all directions, considered to be the thyroid ophthalmopathy or the third nerve palsy or the myasthenia gravis. These are the conditions where you have the diplopia in all the even thyroid arthropathy where you have the graves ophthalmopathy, proptosis, the muscles, extra muscles are become inflamed, will also produce that. In third nerve palsy, you have the complete ptosis, the eye is down and outward. Here you have the dilated, you have the dilated pupil not responding to the light or the accommodation. Here the right eye, here the left eye is affected. In the third nerve palsy is how the clinical condition third nerve palsy looks like. The fourth nerve, the double vision in the down stage when you are going down are the reading books. So ask the patient to and look the cause the vertical hypertropia. This is how the hypertropia. And ask the subject to turn to in and ask them to look down. That cause the vertical hypertropia. This is how the fourth nerve palsy looks like. The sixth nerve palsy, how whenever we have the affected, the failure to the lateral, here you don't see the abduction, the diplopia in the horizontal gaze. This eye is not moving. They have to move to the abduction is not present whenever in the sixth nerve palsy. Then we come to the light reflex. The direct light reflex and the indirect light reflex. Already we have discussed these pathways in detail when we discussed the light reflex, accommodation reflex already in the theory. Each eye is tested separately. The subject is asked to look at a distance. The bright light of torch is brought from the side of the shine into the eye. Result of the prompt constriction of the pupil is seen. When the light is switched off, the pupil will dilate to the previous size. The indirect level, a hand is placed between the two eyes. Light is shining into the one eye, observing the effect of pupil on the unstimulated eye. It is called as the indirect or the consensual reflex. There is a constriction of the pupil now. It is called as the indirect. The pupil of the both will constrict when you throw any light into the one eye. This is the normal pupil constriction. The loss of consensual pupil light reflex. This is the loss of direct light reflex. Whenever we have the lesion of the optic nerve, rapid RAPD is also called as the relative afferent pupillary defect. Whenever we have the palsy of the, whenever we have the multiple sclerosis or demyelinated diseases affecting the second cranial nerve, where you have the retrobulbar neuritis, where involving the afferent pupil, you produce the relative afferent pupillary defect. The loss of the indirect is lost whenever we have the lesions of the third cranial nerve will produce, because the afferent is okay, but the afferent because of the third cranial nerve will produce the indirect light reflex. This is the pathway already we have discussed in detail when you discuss these things. This is the light shown optic nerve. It goes to the optic nerve, pretectal, the superior nerve, and it goes to the Edinger vestibular nucleus and activates even the contralateral Edinger vestibular nucleus, and goes to the ciliary ganglia and goes to the sphincter pupillae and pupillary constriction, produce both the light and the direct and the indirect light reflex. The pathway: retinal receptor, optic nerve, optic chiasma, optic tract, pretectum of the midbrain, Edinger vestibular nucleus, and goes to the oculomotor nerve and the ciliary ganglia, ciliary nerve, sphincter muscles of the iris, constriction of the pupil. For the indirect, it goes to the both and stimulate the opposite oculomotor nerve, ciliary ganglia, ciliary nerves, and produce the constriction of the pupil. The near response of the accommodation or the near response is the three components: the accommodation, the convergence of the eyeball, and the pupillary constriction. Ask the subject to look at the far room, observe the suddenly bring his finger holding vertically about 15 centimeters in front of the subject nose. The subject is asked to look at this. First, you ask the subject to look at concentrated on a distant object. Then you have to bring the subject finger, the examiner finger, or any object in front of the subject 15 centimeters in front of subject knows the response of convergence of the eyes and the pupillary constriction, and when he accommodates the finger, the pupil will dilate as soon as you remove the mode. This is the near response, convergence, accommodation, and the meiosis. This is the pathway where whenever left right visual cortex, the response, and it goes to the left eye frontal left eye, Edinger vestibular nucleus, and the oculomotor ciliary ganglia constrictor, pupillary constriction, and the motor nucleus of the oculomotor nerve. From there, it goes to the medial rectus of the both eyes, causes the convergence, and the even Edinger vestibular ciliary ganglia, constriction of the pupillary constriction. This is how the near response. The three components are the pupillary constriction, accommodation, and the convergence. The lens, near object, and the visual cortex, the accommodation, the superior corneal illness, Edinger vestibular nucleus goes to the medial rectus, and convergence, the ciliary ganglia, ciliary body, and changing of the accommodation becomes and the pupillary constriction focusing near response. The pathway: retina, optic nerve, optic tract, lateral genicular body, optic radiations, the visual cortex to the frontal eye field, then the Edinger vestibular nucleus, and both the oculomotor and the ciliary ganglion constriction of the pupil and the accommodation. Then what is the Argyll-Robertson pupil? Already we have discussed in which the accommodation, the pupil response will be present with the accommodation response, but it don't react to the light. It is seen in the neurosyphilis, the pretectal nucleus is affected. The pupil in which the accommodation reflex is present, but the light reflex, both the direct absent. The lesion is usually neurosyphilis located in the pretectum of the midbrain behind the optic tract. Third neuron, thus interrupting the pathway of light reflex and leaving the accommodation pathway intact. The next nerve is the trigeminal nerve, the fifth cranial nerve. It is a mix of both the sensory and you have the motor component. The fifth nerve supplies the corneal and the palpebral conjunctiva and great part of the face, forehead, temporal region, parietal regions, nasal and the buccal mucosa. The nerve also contains the sensory proprioception fibers innervating the muscle spindles in the muscles of mastication. Even also it has a proprioception from the extraocular muscles also. The sensory function, the corneal reflex and the conjunctival and the general sensations will be testing. The corneal reflex, first you take a light wisp of cotton twisted on the like a fan hair. The subject is asked to look at the far object and approach inside and lateral edges of the cornea, slightly touch with the cotton. Then causes the blinking of the eyes. This responds to bilateral blinking, and you should have to compare the both sides also. The efferent pathway of this reflex is the ophthalmic division of the fifth cranial nerve. The efferent pathway for this is the seventh cranial nerve. From the center of the nucleus is the pons. This is the how you have to touch the lateral, but you should avoid the central cornea. Otherwise, suppose if you have any causes, any abrasion, and you have to use always the sterile cotton. Otherwise, suppose if it is having less sensitivity or it causes any abrasion, will lead to the corneal ulcer and it can affect the. Always you have to, whenever you are checking the corneal with the superficial reflex, you have to touch the peripheral cornea, not the central cornea. Even this is the pathway. When you touch the fifth cranial, it goes into the facial one, the efferent, then it goes to the orbicularis oculi. This is the ophthalmic division of the fifth cranial is the efferent, and the efferent is the seventh cranial, goes to the orbicularis oculi. The conjunctive reflex is also superficial ray, elsewhere in the same manner of the corneal reflex, touching the conjunctiva with the wisp of cotton causes the bilateral, the same pathway. This is how you have to elicit the conjunctiva. This is how you have to elicit the corneal reflex. Then the general sensation of touch, pain, and the temperature of the face are tested with the wisp of cotton, or the pinpricks, or even warm and the cold objects for the thermal temperature. This is the ophthalmic division, maxillary, and the mandibular division of the fifth cranial, the trigeminal. This is the ophthalmic and maxillary and the mandibular division. These are the divisions of the fifth cranial, the central sensation. The forehead and the upper part of the side is known as the ophthalmic division. The malar region and the upper lip for the maxillary, the chin, and the anterior part of the tongue for the mandibular division is the of the general sensation. What is the trigeminal neuralgia? Optic Rex. It is a paroxysmal attack of the severe sharp shooting pain affecting the fifth cranial nerve. It is most excruciating pain caused by the inflammation of this trigeminal nerve. Most probably it is infected by the herpes. Whenever have a herpes infections, whenever you have the Gasserian ganglion, it will become a dormant. Even sometimes if you have the very severe pain, even the absolute alcohol is the olden days we used to inject into the Gasserian ganglion of the trigeminal ganglion, the Gasserian ganglion. Even they used to cut the dissection of the nerve, but they will lose the general sensation of the face. Whenever you suppose if you do they are not able to bear the pain, even they will cut, but there is the loss of the. Nowadays they are using the carbamazepine as the treatment of the trigeminal neuralgia. It is having a good results, but if it is still where you use the alcohol in the Gasserian ganglion or the cutting of the roots, so that but what is the defect with the cutting this will produce a loss of sensation on that side of the face. Then how will you test the motor function? The fifth cranial, the muscles of mastication, the masseter, temporalis, and the medial and the lateral pterygoids, and the temper of the middle ear also it supplies. So the subject is asked to open the mouth and show his teeth. Normally the jaw is symmetrical. If there is any paralysis, the jaw will be deviates to the side of the paralysis because the healthy pterygoids pushing the jaw to that side. Whenever you have the deviation of to the same side, suppose if you have the any fallacy, then the subject is asked to clench his teeth. The temporal and the masseter muscles contract, become the both side prominent. Then you have to palpate these things. Is there any difference in the strength of the contraction of these temporalis and masseters? You have to palpate, not any difference in the strength of the contraction. And you ask the subject to open his mouth and ask him to move the mandibles sidewise. Another thing is the jaw jerk. It is also called as a maxillary jerk. It is tested by placing a finger on the chin below the lower lip with the mouth open, striking with the knee hammer. The tested by this is how you have to perform the. Suppose if it is present, there will be closure of the mouth. Will happens. This response closure of the mouth. That is generally it is very hardly to detect. So whenever you have the upper motor region, these will be exaggerated. Closure normally this is detectable, exaggerated in the upper motor region. Both the afferent and deferent pathway, like the fifth cranial, the center is in the pons. And when already we have discussed these things, there are some of the other tests. When in the second cranial, the visual acuity, field of vision, color vision, we have discussed in detail in earlier classes. Examination of the fundus. Fundus examination is done with the ophthalmoscope. This is the optics of the direct ophthalmoscope. How this is observed for eye, and this is the observed eye. This is fundus will be examined by the direct or the indirect ophthalmoscope, or even nowadays you are using the slit clamp examination. This is how the direct ophthalmoscope. This is the emmetropic. This is the observer eye, the light source. This is how the direct ophthalmoscope principle occurs. This is you have to first do the distant direct ophthalmoscope at a distance of 1 meter, where you have to see any opacities or anything. Then you have come to the closer of the individual. Then you can nowadays with the COVID, these things it may become the obsolete in the future. You have to rely on the indirect ophthalmoscope or the slit clamp slit clamp only. This is the indirect ophthalmoscope. This is the optics of the indirect one. This is now the strong condensing. The direct ophthalmoscopes will give a magnification of the 15 times. The indirect ophthalmoscope give the magnification of the 2 times or 2.5 times is the indirect ophthalmoscope magnification. This is nowadays you are using with the slit clamp biometry, that you can use the 72D lens or the 90D lens, where you can examine the fundus. This is how the fundus examination. Unless you examine the fundus, the second nerve, cranial nerve examination is incomplete. Another test are the stereopsis, which generally, and the contrast sensitivity generally we are not routinely doing. The person and determination of the distance of object means by 3 means the size of the image of the object on the retina. Another is the phenomena of the moving parallax. The phenomena of stereopsis. Stereopsis is the depth perception. The third grade of the binocular vision, where you have the stereopsis. This is the ability to determine the distance of the depth perception. The stereopsis is virtually useless for the depth perception distance beyond the 50 to 200 feet. These are the instrumentation armamentarium used to the Pagolin striated glasses is the one. Another one, the stereotype flight test with this and the TNO T test. These are the random tests of the random stereo acuity tests. These are the tests used to test the binocularity. Even the synoptopore is also used to test the binocular vision or the stereo acuity. The binocular vision, synoptopore or Pagolin striated glass are the polarized projector of the binocular vision field. Measuring the stereo acuity is the various means of dissociating presented in a right and left eye using different colored glasses or the polarized lenses approximately designed for the. This is the basis for the TNO test or the random stereo acuity or the Christmas flight test. These are the tests used to examine the. This is the object, unknown object, and this is how the perception of the depending upon the size of the image on the retina. You can know the distance between the eye. That is one method. Another one is the contrast. Another test is the contrast sensitivity. Contrast sensitivity is a method of the smallest distinguishable contrast to the indirectly assessing the quality of light. These nowadays the contrast sensitivity is becoming whenever you have the LASIK, we are undergoing the LASIK. These tests are done. The contrast sensitivity is assessed by letter of the construct using the different construct grading. Kelly Robinson or the Cambridge contrast sensitivity grading. So these are the charts used to do the testing the car. With this, we will already complete the. Now we will see the how to test with the demonstration videos.
Hi there, my name's Andrew. I'm one of the final year medical students. Could I just confirm your name and age, please?
Yeah, my name's Robert Brown and I'm 21.
Nice to meet you, Robert. Today I've been asked to examine your cranial nerves. These are the nerves that supply your face and your neck. Would that be okay?
Yeah, that's fine.
Brilliant. Are you in any pain at all?
I'm in no pain.
Okay. First of all, Robert, I'd just like to check, have you noticed any change in your sense of smell at all?
No, I haven't.
Okay. Now I'd like to test your vision. Would that be okay?
That's fine.
I'd now like to assess your visual acuity. Do you usually wear glasses, Robert?
No.
Okay, if you could cover one eye with the palm of that hand, and starting at the top, I'd like you to read down as far as you can on the Snellen chart in front of you.
E, H, N, D, F, N, P, T, X, Z, U, Z, D, T, F, D, F, N, P, T, H, P, H, U, N, T, D, Z, N, P, X, T, Z, F, H.
Fantastic. And if you could cover the other eye and do the same.
E, H, N, D, F, N, P, T, X, Z, U, Z, D, T, F, D, F, N, P, T, H, P, H, U, N, T, D, Z, N, P, X, T, Z, F, H.
Brilliant. I'd now like to assess your pupils. This will involve shining a bright light into your eyes. Would that be okay?
Yes.
Brilliant. If you could just pick a point on the wall in front of you and keep looking at that.
Examine the direct light reflex.
That's great. I'd now like to swing the light between your eyes. If you just keep looking at the point on the wall in front of you.
This is a swinging flashlight test. To test the any relative affinity.
Finally, I'd like to assess the ability of your eyes to focus. If you could look at the point on the wall in front of you. And now look at the pen.
Where you can notice the
That's great.
convergence and the transition of the pupil.
Robert, I'd now like to do some specific tests of your vision. If you could just keep looking into my eyes, I'd like you to point at the finger you see moving. Brilliant. I'd now like to test your visual fields. If you could just cover one eye with the palm of that hand for me, I'm going to cover the opposite eye. Let me know when you see my finger moving. Keep looking into my open eye.
Yes. Yes.
He is doing the
Yes.
confrontation visual field testing.
Yes.
Cover the opposite eye for me. Same again.
Yes. 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 Yes.
Brilliant. I'd now like to assess the movements of your eyes. First of all, have you got any double vision at the moment?
No.
Okay. Do let me know if you have any double vision throughout the exam. But I need you to keep your head perfectly still, and I'd like you to follow my finger.
Is H-shaped manner is testing the ocular movements, the versions.
Did you have any double vision at all?
No.
Okay, fantastic. Okay, I'd now like to assess the sensation on your face. First of all, I'll start with a piece of cotton wool and then a small neurotip. Would that be okay?
Yes.
Brilliant. This is what the cotton wool feels like. Can you feel that?
Mm-hmm.
Brilliant. If you could just close your eyes and let me know when you feel the cotton wool on your face.
No. 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 No.
And did it feel the same on both sides of your face?
Yes, it did.
That's great. I'm now going to assess it with this neurotip. Can you feel that?
Yes.
Fantastic. Again, if you could close your eyes for me.
No. 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 No.
And again, did it feel the same on both sides?
Yes, it did.
That's great. Okay, I'm now going to feel some of the muscles around your face now. Just clench your jaw for me and relax. Clench your jaw for me
Master.
and relax. Open your mouth and don't let me close it. I'm now going to assess a reflex, if that's okay. What I'd like you to do is just relax your jaw down slightly for me. I'm just going to place my finger on your chin.
This is the demonstration of the jaws.
Fantastic.
The corneal reflex, conjunctival reflex.
So I'd just like to assess some movements of facial expression.
natural receipt. Your learning objectives for mastering the examination of the cranial nerves and motor system are: review the 3 important principles guiding the neurologic examination, being: is the mental status intact? All right symptom, especially the movements of chin and productive. Common or concerning symptoms relating to the nervous system include headache, dizziness or vertigo, generalized
proximal or distal weakness, numbness, and abnormal or loss of sensation, loss of consciousness, fainting, tentation. Please refer to Chapter 5. 12 pairs of cranial nerves emerge from within the skull and mediate complex motor and sensory functions. Cranial nerve 1 and 2 are actually fiber tracts emerging from the brain. Cranial nerves 3 through 7 arise from the diencephalon and brainstem. Several of the cranial nerves are specialized, producing smell, vision, or hearing. With the patient's health history in mind, and after good hand hygiene, you are ready for the physical examination. To examine the cranial nerves, you may begin with cranial nerve 1, the olfactory nerve, which mediates the sense of smell. If you do assess its function, first be sure each nasal passage is open by compressing one side of the nose and asking the patient to sniff through the other. With his eyes closed and one of the patient's nostrils occluded, pass a mildly aromatic and familiar substance, such as vanilla, clove, cinnamon, or coffee, under the open nostril. If the patient detects the smell, ask him to identify it. Cranial nerve 2, the optic nerve, mediates vision. To assess its function, check the patient's visual acuity, visual fields, and removing glasses if necessary, inspect the optic fundi of both eyes. In the fundi, be sure to inspect the ratio of the caliber of arteries to veins, usually 1 to 3, and changes in the arteries, like vascular narrowing. Also look for papilledema, pallor from optic atrophy, and any cup enlargement suggesting glaucoma. Cranial nerves 3, 4, and 6, the oculomotor, trochlear, and abducens nerves, control eye movements. Because these nerves work together so closely, they are examined as a group. Check the extraocular movements in the 6 cardinal directions of gaze, and look for conjugate movements in any of the 6 directions, which causes diplopia. Ask the patient which, if any direction, makes the diplopia worse. Inspect the eye closely for asymmetric deviation of movement. Determine if the diplopia is monocular or binocular by asking the patient to cover one eye or perform the cover-uncover test. Test for convergence of the eyes by asking the patient to look at your finger as you move it toward the bridge of his nose. Eyes can usually follow your finger to within 5 to 8 centimeters. Identify any nystagmus, an involuntary jerking of the eyes with quick and slow components. Note the direction of the gaze in which it appears, the plane of the nystagmus, horizontal, vertical, rotary, or mixed, and the direction of the quick and slow components. Note that nystagmus is named for the direction of the quick component. For example, right gaze nystagmus. Ask the patient to fix his or her vision on a distant object and observe if the nystagmus increases or decreases. Look for ptosis, which is drooping of the upper eyelids seen in palsy of cranial nerve 3 and myasthenia gravis. A slight difference in the width of the palpebral fissures may be normal variation in approximately 1/3 of all people. The motor portion of cranial nerve 5, the trigeminal nerve, innervates the muscles of mastication. The sensory portion of the nerve mediates facial sensation and the sensory part of the corneal reflex. To palpate the temporal and masseter muscles in turn, ask the patient to clench the teeth. Note the strength of muscle contraction. Then ask the patient to move the jaw from side to side. The sensory portion of the trigeminal nerve has 3 divisions: the ophthalmic, maxillary, and mandibular divisions. To test the sensory portion of the trigeminal nerve, explain to the patient how you will assess for pain.
That is sharp. Okay.
With the patient's eyes closed, test for pain sensation using the sterile sharp end of a broken cotton swab stick or some other suitable sharp object to stimulate the patient's forehead and cheeks at the points indicated. Occasionally, substitute the dull end for the sharp one as you test scattered areas. Compare symmetrical areas on both sides of the face. If you suspect an abnormality, confirm it by testing further for temperature sensitivity by using 2 test tubes filled with hot and cold water. A tuning fork, which usually feels cold, may also be used and made warmer by running it under hot water and drying it before use. Next, test for light touch using a wisp of cotton. Ask the patient to respond whenever you touch the skin. To test the corneal reflex, ask the patient to remove contact lenses, which frequently diminish or abolish this reflex. Prepare a fine wisp of cotton. Ask the patient to look up and away from you. Approach the patient from the side, out of his line of vision, and lightly touch the cornea with the cotton. Normally, the patient's eyes blink and tear. The sensory limb of this reflex is carried in cranial nerve 5 and the motor response in cranial nerve 7. Cranial nerve 7, the facial nerve, innervates all the
Hello, Abby. My name's Amy. May I examine your eyes? Yes.
There are many useful signs on examination of the eyes. An exhaustive list is in the book. Look at the head and eyelid position and consider the parts of the eye in turn. Look for proptosis or forward bulging of the eyeball from above. Now we test visual acuity.
Do you wear glasses? No.
Ask the patient to use their distance glasses if they use them.
Please cover your right eye.
Ensure good ambient lighting. Use the chart at its specified distance and ensure that it doesn't move. Ask the patient to cover one eye with a card and read from the top down until they can no longer distinguish the letters.
Please cover your left eye.
If the patient cannot read down to the bottom line, use a pinhole. If they can't read the top line of the chart, bring the chart closer until they can and record this distance. Repeat this process for near vision.
Please cover your right eye.
Consider the lighting again and the patient's reading glasses.
Hold this at a comfortable distance and start reading from the top paragraph.
The card is printed with prose in type of various sizes. Record the smallest size that can be read accurately.
Please cover your left eye and continue reading.
And better lighted than those of any metropolis in Europe.
Thank you.
To test the patient's visual fields, sit directly facing the patient about 1 meter away.
Please keep your head still and look directly into my eyes.
Test for a homonymous defect with all 4 eyes open.
Please tell me when you see my finger moving.
Now.
Hold your hands out to their full extent and wiggle your fingertip. Ask the patient to indicate when they see it move. Do this at 2, 4, 8 and 10 o'clock. Test for sensory inattention.
Please point to the finger that you see moving.
Both you and the patient should keep your eyes open. Check both sides at the same time.
Please cover your right eye.
Test peripheral visual fields in one eye at a time.
Please look directly at my eye.
The patient covers one eye and you shut your opposite eye.
Please tell me when you see my finger moving.
Now.
Test each quadrant separately and compare your visual field with the patient's. You need to be seated close together so that you can hold your finger in an equivalent position for both your and the patient's eye.
Please cover your left eye. Please look directly at my eye and tell me when you see.
Start with your finger in the periphery out of view and wiggle the tip. Bring your wiggling finger along the diagonal towards the centre of vision. The patient should indicate as soon as they see it moving.
Now. Now. Now.
Next, we test the central visual field using a red hat pin.
Please cover your right eye.
And you close your left.
What colour is the hat pin?
Red.
Test for colour desaturation.
Please keep your head still and look directly at my eye. Please tell me when the pin disappears.
Make a rough map of the patient's blind spot and compare this to your own.
Please tell me when it reappears.
Now.
Can you see it here?
Yes.
And here?
Compare perception of the hat pin in the 4 quadrants of the visual field centrally. Ask specifically about colour desaturation. Next, we examine the eye movements. Hold your finger at least 50 centimetres away from the patient.
Please keep your head still and look at my finger. Please follow my finger and tell me if you see double at any time.
Move your finger to each side and up and down, tracing the letter H in the air. Look for any divergence of the gaze, which you would see, or double vision, which the patient would report. You may also detect abnormal patterns of movement such as nystagmus. Examine the pupils for shape and symmetry.
Please look straight ahead.
Take account of the ambient lighting.
Continue looking straight ahead. I'm going to shine a light in your eyes.
Bring a bright light from the side to shine on the pupil. Look for constriction of the illuminated pupil, the direct light reflex, and of the opposite pupil, the consensual light reflex. Look at the accommodation reflex and gaze convergence.
Please focus on a point on the far wall.
Present an object at about 15 centimetres.
Now look at the tip of this pen.
You should see the eyes converge and the pupils constricting as the eyes accommodate. Use an ophthalmoscope to look at the retina and optic nerve head.
I'm going to have a look at the back of your eye.
Start with the patient's right eye. Hold the ophthalmoscope in your right hand and use your right eye. Find 0 and rotate the lenses clockwise to lens 10.
Please look down.
Gently retract the upper eyelid.
Now focus on a point on the far wall.
Start at a distance of about 10 centimetres and bring the red reflex into focus. The cornea, iris and lens can be seen and any opacity will appear black. Now come close to the patient's head such that you touch the hand you are resting on their forehead. As you do, rotate the lenses anti-clockwise until the retina comes into focus.
Please look up.
By asking the patient to divert their gaze and making your own movements, systematically examine the retina
and left.
Finishing with the fovea.
Please look directly at the light.
all of you have a quick review of the light reflex. This is one of the most important. It is well demonstrated here. This is the direct, where you see observing the reaction of the people. It is well demonstrated here. You see the direct response, where here is examining, there is a direct response.
That's great. I'd now like to swing the light between your eyes. If you just keep looking at the point on the wall.
Here you can observe these people.
That's great. I'd now like to swing the light between your eyes. If you just keep looking at the point on the wall in front of you.
This is a swinging flashlight test for the RAPD, relative afferent pupillary detect. When you want to do, this is called a swinging flashlight test.
That's great.
Accommodation reflex. Okay. With this, we conclude today's session. Okay. Thank you.